Hello, my name is Alvaro Galvis. I am a Pediatric Infectious Disease Fellow at Children's Hospital, Orange County, California, in the United States. Today I will be presenting the safety of COVID-19 convalescent plasma for the treatment of moderate to severe cases of COVID-19 pediatric patients. Convalescent plasma has been successfully used in infectious syndromes before, most notably the Spanish flu of 1918, SARS, MERS, and Ebola. More recently, convalescent plasma has been used in the adult population with good safety profiles. The challenge in the pediatric population is that children have viral illness with hospitalization rates of 8 per 100,000 as opposed to 164 per 100,000 in the adult population, and children have an estimated case fatality rate of only 0.2% as opposed to about 16% in the elderly population, most notably 85 years old and older. Therefore, the risks and benefits of intervention in COVID-19 for the pediatric population is going to be rigorously balanced because of its low morbidity and mortality. Based on the historical precedent of prior infectious syndromes, we decided to study convalescent plasma for COVID-19 in children. We enrolled a total of 16 patients ranging from 1 month to 25 years old of age. Each of these patients was positive via nasopharyngeal swab, RT-PCR, and had actually developed respiratory syndromes, most notably by having an increased oxygen requirement. Each of these patients received COVID-19 convalescent plasma, which I'll refer to as CCP. CCP was obtained from volunteers with proven previous COVID-19 illness and which had already resolved. Antibody concentrations were measured in ELISAs on all CCP prior to infusion. Antibodies were also measured on CCP recipients after infusion of kinetics, days 1, 7, and 21 days. Safety laboratory and clinical parameters were required to identify trolley, transfusion-related acute lung injury, TACO, transfusion-associated circulatory overload, and AD, antibody-dependent enhancement. Our results are as follows. When we looked at the safety profile, we first looked at white blood cell count, hemoglobin, platelets, fibrinogen, D-dimer, pre-infusion, 24 hours post-infusion, and 7 days post-infusion. We did an ANOVA analysis on these parameters and found that for the white blood cell count, hemoglobin, fibrinogen, and D-dimer, there was no significant difference, as noted by an F critical value greater than the F value. The only significant difference was found in the platelets, in which the F critical value, meaning the null hypothesis, was less than the F value. Most notably, in the platelets, the mean continued to increase to normal levels. Hence, throughout the disease process, this thrombocytopenia was resolving. As far as our antibody kinetics, it's important to note that all CCP had actual levels for COVID-19 IgG. Our patients did not have any IgG detectable, very low. Then 24 hours post-infusion, they had detectable antibodies, as denoted by the green bar, and those levels continue to increase above the initial convalescent plasma levels given, and these levels attained up to day 21 post-infusion. Therefore, our conclusions are as follows. There was no infusion-related toxicities during CCP administration or ADE were noted. Patients experienced an immediate increase in SARS-CoV-2 antibodies after CCP infusion. At 7 and 21 days after infusion, median antibody concentration was higher, suggesting patients' own antibody response. Thank you very much for going over my e-poster, and I'll take any questions via email or the comments section.